Evening, we have with us Dr. Asif Iqbal, a respiratory critical care specialist from the Apollo Multi-Speciality Hospital. And we welcome you to Natco Pharma Specialty Studio. We love to hear your insights, Doctor, especially towards the younger generation doctors in the space of critical care, as well as those that are associated with antibacterial resistance. My first question is, how do you foresee the changes in the critical care management?
No, thing is that now no more India is a developing country. I believe in the critical care field, we are developed country. We as good as developed country, and we are also our diagnostic ability is as compared as Western country, and also the we follow the guidelines. We have also Indian guidelines and the Western guideline also we have, and it's more or less similar because why needed Indian guidelines, because our patient is little different than the Western patient as compared to uh, the genomics, as compared to the volume of distribution of the drugs. Everything pharmacokinetics and pharmacodynamics is in Asian countries patient is different than the Western countries. So we believe our guidelines is more comparable for our patient. And regarding the infection, regarding the fluid management, regarding the goal directed therapy, these are the thing we have a individual guidelines, and we follow the Indian guidelines along with the we compare with the Western guidelines. And nowadays the big headache all over world, that is a epidemic threat, that is not infection, is a multi-drug resistant infection. How will we battle this multi-drug resistant bacteria? So nowadays in India or in Asian country, the more threat is the gram negative rather than the gram positive. In Western is completely different. They are more gram positive than the gram negatives. Though right now they are also increasing the gram negative resistant bacteria. But in India, we face more challenges to multi-drug resistant or extended drug resistant gram negative bacteria like your escape bacteria, carbapenems resistant, your that is E. coli, MDR E. coli, Klebsiella, Acinetobacter, and the Pseudomonas. Among these two, the Klebsiella and the Acinetobacter is great headache for intensivists like us who are working in the multidisciplinary hospital. We have a patient load high, we have a infection load also high.
Thank you for recognizing India as a developed nation, in the
I
critical
believe.
care. I am of the same opinion too. What is your advice from your experience to the younger set of doctors today in the ICU for them to enhance patient care?
First of all, I will tell all the younger generation who want to work in the critical care, they must be dedicated, focused, because critical care is not a specialty, it's a super specialty right now. And it needs the dedication about the knowledge and about the practice also. And most of the ICU nowadays, we try to give the services protocolized. Like there should not be difference between one hospital to other hospital. So that's why the guidelines work. And regarding this uh, patient management, the point of care things like you have to have the point of care services like USG at the bedside, and also for the recognized infection you have to have the diagnostic facilities. And moreover, I will tell for my young generation, when you are prescribing any drugs, so you have to know you have to have the knowledge of the drug, like simple for the antimicrobial agent. When you are prescribing, you have to know the where is the source and what source you are expecting. So you are targeting this, particularly if the infection in the blood, you have to know what are the antibiotic work in the blood. Simple example, like there is a Klebsiella and sensitive to TG cycline, but it's showing that this Klebsiella in the bloodstream infection. So TG cycline is not work in the bloodstream. So you have to have that much knowledge before prescribing the antibiotics. So I always tell my junior, when for the antibiotic, when you are prescribing, you should you have a question and its answer. Where is the infection? What infection? And what antibiotic we are giving? Whether there is a penetration is there or not, and the PK/PD of the antibiotic. So if you have a clear about the four thing, any infection you can battle. And you have to have knowledge the genomic structure of the bacteria. Rather, the culture sensitivity, obviously it is good, but at least if you have the genomic sequence, it is better to manage, easy to manage.
That's a volume of advice you've been sharing to the younger doctors. What is the prevalence of carbapenemous producing bacteria in your practice, and what are the treatment options?
Uh, it is similar kind of all metro city ISO have similar kind of resistant pattern about the carbapenemase. In my hospital, is 90% Klebsiella is carbapenemase resistant. 90% Acinetobacter is carbapenemase resistant. So nowadays, when we are junior, we used to give the meropenem, which is a amrito, sanjivani. If you give meropenem, patient will survive. But nowadays, 90% is carbapenem resistant. So, if you give the monotherapy with carbapenem, is nothing. It's just simple water. So it's better either you are giving the combined therapy, or it's better you avoid if you are anti-biogram of your ICU showing that prevalence of carbapenemase. So avoid carbapenemase empiric therapy. You can give alternative like ceftazidime avibactam combination with aztreonam, because most of the Indian ICU they have prevalence of MDR acinato or MDR Klebsiella. Again, if you have the MDR acinato is prevalence, so ceftazidime avibactam will not work. Then you have to go by polymyxin. You have to add the polymyxin.
Dr. Asif Iqbal, thank you for spending your valuable time with us in the Natco Pharma Specialty Studio today, and we wish you all the best in your practice.
Thank you.